I usually start off this lecture with some Pseudomonas stuff, but I'm going to try to, it's not your typical antibiotic lecture. I don't usually go, there's not a ton of systematic stuff in this lecture, but I'm just going to make random connections left and right. So feel free to use that blank sheet of paper to just sort of write down however you want to. But we're going to start off with Pseudomonas because this is how I started giving this lecture. By the way, I hate antibiotics. I didn't understand them until maybe I was a chief. So, and I'm still learning. So, which antibiotics cover Pseudomonas? Steph has. Okay, so we'll just go. And yeah, my goal is to get a bunch of antibiotics on the board and we'll talk about them. So, okay, all right. Cephalene. All right. Oh, sorry. What else? Zosyn. All right. So I'll go with Tazosyn. All right. Anything else? Amikacin. So yeah, we'll go with the aminoglycosides, and one of them being amikacin. I always say, or the adults always say, don't let anyone die in ICU without one dose of amikacin. So that's how I remember amikacin. But remember, aminoglycosides are rarely good for single therapy, so you should always be adding them on to something else for the most part. Okay, what other aminoglycosides are there? Gentamicin and one more? Oh yeah, tobramycin. All our CF kids have Toby Mendems, right? All right. What else?
Cipro.
Yeah, ciprofloxacin. So yeah, and then levofloxacin, and we'll just say fluoroquinolones. There are other ones like Moxie, but Moxie does not cover it. So I'll just say no Moxie. We don't use it in kids anyway, so it doesn't really matter. Now we're starting to get to like the random ones, but there's a big one that we use that ID has to approve. All right, so carbapenem. Yeah. So there's classically meropenem. What else? What other penoms are there? Yeah, the carbapenem. There's two more. One's Dory. Finding Dorypenem. Okay. And there's Erda, but nobody. Erdapenem does not have coverage. So really, we just use meropenem. So we don't have to think too much about those. But all right. Anything else? This one's if you're pen allergic. Yeah, Astrinum. Yeah. Okay. It's a class of antibiotics in monobactam. All right. Anything else? We're getting close. So Pseudomonas resistance is becoming more and more of a big issue. Superbugs, and so we're actually getting to the point where like they're meropenem resistant, and so by that time you have to go to things like colistin and polymyxin. So I've only done this on the adult side, so don't worry about it too much. Okay, so obviously my stupid Pseudomonas P rule, I don't know, I just could never remember, so I just started putting P's in random places. So ceftazidime, cefepime, you'll notice they all have P's. Aminoglycosides, not really, but I tried. Ciprofloxacin, so that's how I know that the fluoroquinolones cover it. This doesn't work for all P's, right? Because penicillin doesn't cover Pseudomonas, but if there's carbapenem, meropenem, Pastrianam once again, so I made this one a P, and polymyxin, so. But yeah, so once again, like, I think that's how I started off this whole antibiotic series, and so I think that's all I'm going to say there about it. So there are a couple other cephalosporins that do cover, like what is it? Ceftazidime and ceftriaxone, but we don't use those right now, so I won't go over those. Okay, any questions on Pseudomonas? I was just trying to get a bunch of antibiotics on the board, and then of course after my Pseudomonas B lecture, I went over to do MRSA. Because they're always, we want to cover MRSA. What actually covers MRSA out there? So, what covers MRSA? Okay, so everyone knows vancomycin. So, the good news about this list is all these lists are about 10 antibiotics long. So we'll have to go 9 more here. Clindamycin. Okay, so the random side point for clindamycin here is they always like, oh, what's the D test, right? So, huh? Yeah, go
I'm
ahead.
gonna answer, but it's fine.
Yeah, go ahead. You're right. That's what I'm asking.
There's erythromycin resistance initially. They always do the D test because it induces resistance to clindamycin.
Yeah. So yeah, she's definitely got a very technical way, and she actually understands it. I just go, if the D test is positive, it's resistant. But it's hard to remember that, so it's probably better that Yara actually remembers the erythromycin. They put it on the plates. I'm not an ID doc. Yeah. And stuff happens. But if it's D test positive, that means it's resistant to MRSA. Okay, so you'll see that reported on your things.
Wait, resistant to MRSA or resistant to?
MRSA is resistant to. Yeah. Thank you. Resistant. MRSA resistant. Like it doesn't cover MRSA. I'll just put it that way. All right. What other ones?
Bactrim?
Yeah, Bactrim. So, trimethoprim. So, hospital so long, and that's why everyone calls it Bactrim, but people also call it etc. It's just branding. Okay, what else? Linezolid, okay. That's what I didn't learn a whole ton in med school about, but it's definitely being used a lot more commonly now. And, okay. Yeah, what's special about linezolid? Yeah, you have a PO option for it. Like, right, so you can't send home someone with PO Vanco because PO Vanco really just only affects the gut. So I remember from Micro made ridiculously simple, like you want to treat C. diff, you have like a metro and a van driving down the intestines and it just sort of kills everything there. But you'll remember Vanco doesn't actually get absorbed orally into the rest of the body. So, so yeah, a lot of times your PO Vanco equivalent sometimes is linezolid. Okay, what else?
There's like cephalosporin, like a fifth class. Or
Yeah.
Ceftaroline.
Ceftaroline, okay. I just came back from North Carolina, not really an association, but yeah, this is the 5th gen, and it's just coming down the line. I haven't seen it used yet though, but good. Yeah, daptomycin does cover it. Yeah, now we're starting to get like really out there. Yeah, like, I mean, I guess ID still uses some dapto, right? They also, but more commonly in osteo, they also throw on their vamping, yeah. For synergy there. Good. And did you know actually jet can also be used for synergy too? Who would have known? I didn't know that until I, prepared this a little bit more. So, okay. Any others? There's a common one that's it's not becoming more and more used. It's doxy. Yeah. Now we're just getting out there, so I'm not even going to ask. So, Pristine, Dolfo, Pristin. And then, what about if you have impetigo? Yeah, so ibuprofen. So this one's topical, right? So, and then, just to be complete, we'll do telavancin. But I haven't seen this used either. So, but okay. So now that I've got these on the board, I'm going to go over like the PO and the IV. So is Steptown PO or IV? IV. Cefepime, IV. Zosyn, IV. Immunoglycosides. Yeah, IV, and then this is a med dev, right?
Do you want a different color?
Sure. Thank you, sir. Okay. Cipro. IV and PO. Vivo. IV and PO. How about the Penoms? Estrinum. IV. Colistin. IV. Polymyxin. I think it's IV. I'm not sure on that one. So, okay. Huh?
Med dev the estrogen.
Oh, really?
Yeah.
Oh man. Okay, man, I've been gone from CF too long. All right, Vanco. IV, PO, and PR. You can give it rectally, so.
But not
For C. diff. Not for MRSA. You're right.
Not for MRSA,
Yes.
yeah.
So let's just do that right now, since we are talking about MRSA. But I'm just talking about in general. Like I'm using this to talk about each of the antibiotics a little bit. But yeah, you're absolutely right that it does not cover MRSA PO. Clinda, IV, and PO. Bactrim, Mostly PO, some IV. Yeah. PO, ceftaroline, I think it's IV. Dapto, I think there's actually a PO. I'm not 100% sure. So, question mark on that one. Rifampin. Do they ever send kids with PO rifampin home?
Oh, yeah.
Yeah, right? We have, okay. And then there's IV. Doxy, PO. Actually, I don't know if there's IV here. So I'll have to keep on improving on that. All right, this is topical, we already said, and telavancin is probably IV. But, so one thing to notice as I put those out there, though, is if you look at Pseudomonas, which oral regimens do you have to send all these Team D kiddos home with? You really have Cipro and Levo, right? That's pretty much what you have there. So what's the difference between Cipro and Levo? What were you sort of taught in med school about them? Yeah, which one is which? So Levo is a respiratory fluoroquinolone, and the reason you can think about it that way is you can think about Levo actually having atypical coverage. So that's, and then Cipro, you know, like you should have, okay, woman has a UTI, give her Cipro, and now we overused it, and now it's like worthless. So, so think of, both of them can be used for, you know, respiratory stuff, but Levo's got better atypical coverage. So, but yeah, you'll notice the rest of them are IV, so it's not a whole ton going on there. For MRSA, obviously you have more options. Linezolid, think of it more classically for more pneumonia-related stuff. It's not, and I think skin and soft tissue too, but not like for everything else. Okay. It took me years of giving this lecture for me to actually understand what I was giving. So, okay. All right, anaerobes. What covers anaerobes now? Okay, clindamycin. What else? Metronidazole. We'll just call it Flagyl too. All right. Which one? Piptazo. Okay.
Unison?
Huh?
Unison?
Okay, unison. So, ampicillobactam. Okay. What's the difference between Piptazo and ampicillobactam? Like, why would I use this? Oh, wow. Okay, so they actually have decent gram-negative coverage both. It's Pseudomonas coverage, right? So it doesn't show up on this one, but it shows up over here. So, okay. How about, yeah, we'll go with amoxiclavulanate. Our favorite drug, right? Augmentin. So now you're like, oh, what's the difference between ampicillobactam and amoxiclavulanate? Yeah, pretty much. Like, you think of them as twins, right? Like, if you want to give IV for them, you use unison. If you want to give a PO, it's augmentin. So actually, when you think about it, when you give kids, like, you know, for, you know, sinusitis and, you know, ear, blah, 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 you know, upper respiratory tract stuff, you're actually giving a pretty broad spectrum antibiotic when you give augmentin. Like, you know, it's like, if you think about it, like, when I just blast a kid with IV unison for, you know, sinusitis, you're like, oh, you know, but we're getting to that point where we have to. So, but it's just another reminder, hey, do I always have to go amoxiclavulanate, or can I just go amoxicillin? So, all right, and there's one more, just carbapenems. Okay, so I didn't do this earlier, but MRSA-M's, this sort of works. Not really. Trimethoprim, line-mesolid, or something like that. Ceftaroline, daptomycin, rifampin, oxycycline, Pristin, I don't know. Mupirocin, that one works at least. So the anaerobes really, yeah, like obviously this doesn't quite work, but hey, it's good enough. So there's something in everything. All right, so now that all the antibiotics on the board, and I give you some of the pre-test more just to like, if you've gone ahead and filled it out, feel free to just pass it in. It's not like I'm testing you guys on anything, but I want to know for the future. But now that they're all on the board, we can compare them. So, and probably the best thing is just to go through the pre-test, like, and because I don't actually have all of them on there, ceftriaxone and cefotaxime. Oh, actually, before I go back to that, clindamycin, IVPO, both. Okay. Metronidazole, IVPO, Zosyn, IV, we already did this, carbapenems, IV, okay, so, all right. Okay, so what's the difference between ceftriaxone and cefotaxime?
Isn't it the biliary sludge?
Yeah, so definitely there's biliary sludge in less than 1 month old. So it's sort of a technical point, but that's why when you look at all your NICU babies, none of them are on ceftriaxone. They might be on cefotaxime or Gent, but they will never be on ceftriaxone because it causes biliary sludging less than 1 month. So that's one difference. What's another difference? See, I like comparing antibiotics because, like, if they're really similar to each other, it's like you just, if you know, okay, it's just the IV form and PO. These are just pretty much equivalent in almost every other way. It's just how they're given. How are they given?
Q6Q8 versus Q8.
Yeah, so the cefotaxime is what, Q6, Q8-ish?
Yeah.
Well, ceftriaxone is
12 to 24.
12 to 24. So why do you think the ER likes Rocephin? It's one of those, like, you can also give it IM, right? So if kids got carving, pump them full of IM ceftriaxone. You can do it in clinic too. And then it's really good for 24 hours. So it's like one of those, like, give it to them and you just like kick them out and they're going to be fine. In a sense, you don't have to like really follow them up as closely. So that's why they give vitamin R all the time. Cefotaxime is not as often given now because there's just a national shortage. But I think it's helpful to know they're the same thing, but just given in different frequencies. If you're going to send someone home with IV antibiotics, you're like, do I really want them to do something Q6, Q8 if I don't have to, in a sense? So.
Doesn't Cefotax have better CNS penetration?
They actually have, both of them have pretty good CNS.
Oh, it's
yeah,
better.
but a lot of people still go with Cefotax. Yeah, a little bit more than ceftriaxone in CNS stuff. But that leads me to the next point. Actually, no, I won't go there yet. Actually, it is. When is cefotaxime better than Peptazo?
It is for meningitis.
Yeah, meningitis. That's the only reason. And that's so because when you think about it, ceftriaxone, cefotaxime is a broad spectrum, but a lot of people will go with Zosyn, and you're like, okay, why is Zosyn? What is the one instance where these are actually better? And it's really meningitis. Where is Zosyn better than ceftriaxone and cefotaxime? Yeah, so, sorry, it's not super random. Pseudomonas
And then anaerobe.
and anaerobe. Those are the two things. Okay. So, you could definitely see it from here, but also just remembering. So a lot of times, hey, when a kid's coming in and it's got like a pneumonia or something, or like sepsis and stuff like that, and you're trying to think, do I want to start them, which broad spectrum? You go like, okay, Zosyn Vanco or ceftriaxone Vanco. You have to go, well, am I concerned about Pseudomonas and am I concerned about anaerobes in a sense, aspiration, whatever it is, then that helps you decide between those two. Okay. That is probably the one thing, I wish I should have known that a little bit earlier. So, what's the difference between a MOX and AMP? Yeah, just simple, yeah. So once again, that's why, once you remember this, you can remember that pretty easily. Okay, now, the difference between amox, clavulanate, and amp sulbactam. Oh, we already talked about that, just IV and PO. And, all right, now the questions get a little harder. All right, not terribly, but what does vancomycin cover that Zosyn does not? Oh, MRSA. Okay. Anything else?
I mean, if PO, it's
CDID. And Vanco's just got a little bit better gram-positive coverage than Zosyn. So increased gram-positive coverage. Okay. All right. Okay. And we already talked about why is Zosyn more broad spectrum than sulbactam, or better than Unison and Augmentin. Pseudomonas coverage. That's pretty much what it is. So you'll realize in the hospital a lot of times, if we don't need Pseudomonas coverage, like we shouldn't be using these anyways, right? So, and you'll see your dental abscesses or like those kinds of kids, cervical stuff, they do a lot of Unison, right? Because they want to cover for anaerobes. But you'll also see them do some Clinda too, right? And flagell, but you rarely see Peptazo because you don't need it. You don't need the pseudomonal coverage up there as much. I don't know. A new book, to be honest, on that one. So, okay, what's the difference between cefazolin and cephalexin? One more time? Yeah, so this is just IV and this is PO. Once again, two sides of the same coin again. And that's why, like, I mean, we're not surgeons, but like every time they're going to cut into someone, they always give a gram or two of Ancef, right? Huh? Yeah. Oh yeah. Sorry. Yes. Thank you. That's the way. And this is Keflex. So that tells you they have really good coverage against skin flora. Skin flora mostly being. Strep. So, all right. So once again, these are first generation. So the first generation have great gram-positive coverage, and then they have some gram-negative too. Then you move up to like this is the third generation here for ceftriaxone, cefotaxime. It's got weaker gram-positive coverage, but better gram-negative. So I usually like to say this. This is why you'll see a lot of Keflex or cefazolin, or just Keflex with regards to skin and soft tissue infections, because they're mostly staph and strep. Makes sense. But they have some gram-negative coverage, which is why some people use Keflex in terms of urinary tract infections. Okay. All right. What's the difference between ceftaz and ceftriaxone? Yeah, it's Pseudomonas coverage. So, but that's why ceftaz is better than cefotax or ceftriaxone. But there's oftentimes a trade-off in terms of antibiotics. What's the trade-off here, though? This one is a little bit harder. Actually, cefotax and ceftriaxone have better gram-positive coverage. So in a sense, ceftaz has no gram-positive coverage. That's also the other big thing to take home. So you'll notice a lot of times, like, hey, we don't start off with ceftaz because we don't need Pseudomonas coverage. And also a lot of times we do some cefotax and ceftriaxone, let's say in a pneumonia or something like that, because there's some gram-positive stuff, right, going on there, and that's why there's coverage. So yeah, when you use, but you're like, oh man, I gotta worry about Pseudomonas, you switch over to ceftaz, you have to remember you lose this gram-positive coverage there. So, okay, and then what does vancomycin not cover? That's probably a good question because you're like, oh, let's just start on vancomycin. Okay, yeah, atypicals is actually a huge one.
And then the gut one, what is it? One of the gut ones that Flagell is better at than Zosyn. What is it? Bacteroides?
I don't remember that. Really?
One of the gut ones that Flagell is better than Zosyn for.
Huh, okay. Maybe I'll have to take a look
I'll
at
let
that.
you know.
Yeah, totally.
That's why for like our neck babies, it's all three of them.
Oh,
Yeah.
really? Okay, cool. All right. That will be, yeah, Yara will hook me up later. VRE is a big one. Let's see if you do IV form. And then actually the big one is actually ESPL. So I'll be honest, ESPL for a long time confused me. It's actually a really simple concept, but someone want to like try to like define ESPL? Like what is when you say, oh man, this is like E. coli's ESBL, what does that mean? Okay, so practically for antibiotic choice, what does that mean? It means carbapenem. When you see ESBL, you just got to go like, hey, there's really few things left to go except carbapenems. So essentially, these are just ESBL, just like, hey, it's got an enzyme that really makes it really super resistant to everything except carbapenems, and that's all that means there. You'll notice maybe just some other random thoughts. You'll notice like the cephalosporins don't have MRSA coverage except this ceftaroline. So I guess so. This one, neutropenic fevers, right? And don't ICU, don't let them die without that. We talked about this being respiratory. We talked a little bit about like atypical coverage. So that's why levofloxacin is better than ceftriaxone and cefotaxime, is it's got atypical coverage. So you'll notice like in some of your community-acquired pneumonias, ID will do ceftriaxone and azithro, right? You guys notice that? I mean, yeah, right? In the hospital, ceftriaxone and azithromycin for community-acquired pneumonia. So the ceftriaxone doesn't have any atypical coverage, but the azithro does. Some people will do levofloxacin instead. Why would you choose levofloxacin over ceftriaxone and Zithro? So levofloxacin doesn't have like good MRSA coverage. Maybe it has a little bit of MSSA coverage, but huh? Yeah, if you're concerned about Pseudomonas, that's one thing. But what else? It's like actually, I just had a kid in my clinic yesterday. He's got prolonged QT actually. Zithro causes prolonged QT, but so does this. So that's a terrible example. All right, I'll just leave that. Yeah, you're like, wait a second. Yeah, but also just like they really moved and said, hey, you know, the fluoroquinolones, apart from these like beagle tendon ruptures, are just not really good first lines in adults or kids. But if you have to use it, you have to use it. So.
This is gonna be nerdy, but where do we get the antibiogram?
Yeah.
This year?
Yeah, actually, yeah. So they don't actually have this year's out yet. They have. Do you guys know how the antibiogram works? Yeah, so they actually just take all the isolates, like all the studies you order, and then they just sort of like put a table out there, like saying what percent is actually resistant to this antibiotic for this organism. A pediatric one and an adult one. And the cool part about that one is actually when I have a smaller audience, I actually just pull that out and I actually say, hey, look at Pseudomonas, and it'll actually say which of the it'll actually list all the bugs, all the antibiotics that cover Pseudomonas there, and you see the resistance patterns. And so it actually sort of lines up with what this is right here. So once again, the hard part about antibiotics is as we use more of them, like they become resistant and like they're less and less effective in different parts of the country. So what's true today is not necessarily going to be true, 5 years down the line in a sense. So, all right, any other comparisons? Okay, why would you use Clinda over Flagyl? Okay, so there's MRSA coverage for Clinda. What else is there? You ever? Yeah, it's actually gram-positive coverage. You never see Flagyl given for like cellulitis or something like that. So there's definitely more gram-positive coverage, and Flagyl is mostly used for anaerobic coverage. So that's why you go, like, let's say, this is a different lecture, but like, if you have aspiration pneumonia, what kind of antibiotics do people typically give for that? Yeah, they'll give some Clinda, which once again has some, you're like, oh, okay, that covers for some MRSA, that's cool, and then some just staph and strep in general. But yeah, and people use Zosyn, or they'll do something like ceftriaxone and add something like Flagyl or Clinda or something like that. So
why add Flagyl?
Why did they add Flagyl?
Yeah, for aspiration.
For anaerobic coverage. Yeah, I'll be honest, I'm still trying to understand the PEDS ID side of things with like having Clinda and Flagyl at the same time. Yeah. I don't remember. I think I asked Dr. Borg once, but I forgot the answer. So.
Isn't there something where it's like, and I may be wrong, like Clinda above the belt and Flagyl below the belt? Is that?
I mean, classically, that's how people think of it. Sort of like that's why if you have an intra-abdominal infection, a ruptured API, what kind of antibiotics do you do for that? Yes. So some people will go ciproflagyl. And some people will go Zosyn. So once again, in this situation, you go like, okay, ciproflagyl, make sure we have the gram-negatives from ciprofloxacin and the anaerobes from Flagyl. And then Zosyn has gram-negative coverage and anaerobic coverage as well. And that's why people will choose that. So
wait.
Oh, sorry. So we have a patient that has a ruptured API that has Flagyl and Zosyn. And
So we don't understand why.
That's the thing
that's
I was
what she
telling
was
you.
saying.
It's something, I'm trying to look it up.
Oh, okay, so maybe-
It's some of the gut, one of the gut.
oh, the whatever.
The
Maybe
anaerobic,
it's
it's the gram-negative anaerobes that are covered
Yeah.
more by Flagyl and not Zosyn.
yeah, okay, not back to rate. Okay, we'll just take that out.
It's some gram,
Yeah.
like anaerobic gram-negative.
So obviously part 2 of this lecture is I actually go through systematically like, okay, if I have a skin and soft tissue infection, I have cellulitis, UTI, pneumonia, like what are the common bugs? And then like based off what we know here, this covers a lot of stuff, then why do we choose what we choose? But maybe we'll do that another time.
Thank you, Andrew.
All right.